Hello and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Sonam Puri from Moffitt Cancer Center, co-chair on Therapy for Stage 4 Non-Small Cell Lung Cancer with Driver Alterations, ASCO Living Guideline, version 2026.3.0. It's great to have you here today, Dr. Puri.
Thanks, Brittany.
And then just before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Puri, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to dive into the content that we're here today to talk about, Dr. Puri, this living clinical practice guideline for systemic therapy for patients with stage 4 non-small cell lung cancer with driver alterations is updated on an ongoing basis. So what data prompted this latest update to the recommendations?
So, Brittany, non-small cell lung cancer is one of the fastest moving areas in oncology right now, particularly when it comes to targeted therapy for driver alterations. New data are emerging continuously from clinical trials, regulatory approvals, real-world experience, which is exactly why these are living guidelines. The goal is to rapidly integrate important advances as they happen, rather than waiting for years for a traditional update. Since the last full update of the ASCO Stage 4 non-small cell lung guidelines with driver alteration published in 2024, there have been 7 new regulatory approvals and changes in first-line therapy for some driver alteration. The 2025 version 2 of the Stage 4 non-small cell lung guidelines with driver alteration represents a full update, which means that the panel reviewed and refreshed every applicable section of the guideline to reflect the most current evidence across therapies, including sequencing and clinical decision-making. This is to ensure that clinicians have up-to-date practical guidelines that keep pace with how quickly the field is evolving.
Absolutely. As you mentioned, this is a very fast-moving space, and this full update helps condense all of those versions that the panel reviewed before into one document, along with additional approvals and new trials that you reviewed during this time period. So then the first aspect of the guideline is there's a new overarching recommendation on biomarker testing. Could you speak a little bit to that updated recommendation?
Yeah, definitely. So the panel has discussed and provided recommendations on comprehensive biomarker testing and its importance in all patients diagnosed with non-small cell lung cancer. Ideally, biomarker testing should include a broad-based next-generation sequencing panel rather than single gene tests, along with immunohistochemistry for important markers such as PD-L1, HER2, and MET. These results really drive treatment decisions, both in frontline settings for all patients diagnosed with non-small cell lung cancer and in subsequent line setting for patients with non-small cell lung cancer harboring certain targetable alteration. Specifically in the frontline setting, it helps determine whether a patient should receive upfront targeted therapy or immunotherapy-based approach. We now have strong data that shows that complete molecular profiling results before starting first-line therapy is associated with better overall survival and actually more cost-effective care. Using both tissue and blood-based testing can improve likelihood of getting actionable results in a timely way. And we've also provided guidance on platforms that include RNA sequencing, which are specifically helpful for identifying gene fusions that might be otherwise missed with other platforms. On the flip side, outside of a truly resource-limited setting, single-gene PCR testing really should not be routine anymore. This is what the panel recommends. It's less sensitive and inefficient and increases the risk of missing important actionable alterations.
Understood. I appreciate you reviewing that recommendation. It really helps identify critical individual factors to match the best treatment option to each individual patient. So then following that recommendation, what are the updated recommendations on first-line therapy for patients with stage 4 non-small cell lung cancer with a driver alteration?
Since the last full update in 2024, there have been 4 additional interim updates which were published across 2024 and 2025. Compared to the last version, there have been several updates which have been included in this full update. One of the most important shifts has been in first-line treatment of patients with non-small cell lung cancer harboring the classical or what we call as typical EGFR mutation. The current version of the recommendation is based on the updated survival data from the phase 3 FLAURA2 and Mariposa studies, based on which the panel recommended to offer either osimertinib combined with platinum pemetrexed chemotherapy or the combination of amivantamab plus lazertinib in the first-line treatment of classical EGFR mutations. And these recommendations, as I mentioned, are grounded in the results of the FLAURA2 and Mariposa trials, both of which demonstrated improvement in progression-free survival and overall survival compared to osimertinib alone in patients with common EGFR mutations. That being said, the panel actually spent significant time discussing the toxicities associated with these treatments as well. These combination approaches come with higher toxicity, longer infusion time, increased treatment frequency. So while combination therapy is now recommended as preferred, the panel has recommended that osimertinib monotherapy remains a reasonable option, particularly for patients with poor performance status and for those who are not interested in treatment intensification after knowing the risks and benefits.
Absolutely. It's important to consider both those benefits and risks of those adverse events that you mentioned to match appropriately individualized patient care. So then beyond those recommendations for first-line therapy, what is new for second-line and subsequent therapies?
So this is a section that saw several major updates, particularly, again, in the EGFR space. The first was an update on treatment after progression on osimertinib for patients with classical EGFR mutation. Here, the panel recommends the combination of amivantamab plus chemotherapy, and this recommendation was based on the phase 3 Mariposa 2 trial, which compared amivantamab plus chemotherapy with chemotherapy alone with progression-free survival as the primary endpoint. The study met its primary endpoint, showing an improvement in median PFS with the combination of amivantamab plus chemotherapy compared to chemotherapy alone. And as expected, the combination was associated with higher toxicity. So although the panel recommends this regimen, the panel emphasizes that patients should be counseled on the side effects, which may be moderate to severe with the combination therapy approach. In addition, a new recommendation was added for patients who are not candidates for amivantamab plus chemotherapy. In those cases, platinum-based chemotherapy with or without continuation of osimertinib may be offered. And the option of continuing osimertinib with chemotherapy was recommended and supported by data from a recently presented phase 3 COMPEL study, which randomized 98 patients with EGFR exon 19 deletion or L858R mutated advanced non-small cell lung cancer who had experienced no CNS progression on first-line osimertinib. And these patients were randomized to receive platinum pemetrexed chemotherapy with osimertinib or placebo. Although this study was small, it demonstrated a PFS benefit with continuation of osimertinib with chemotherapy, and this approach may be appropriate for patients without CNS progression who prefer or require alternatives to more intensive treatment strategies. Next was an update on options for patients with EGFR mutated lung cancer after progression on osimertinib and platinum-based chemotherapy. Here, the panel recommended that for patients whose disease has progressed after both osimertinib and platinum-based chemotherapy, a new drug known as datomotamab deruxtecan can be offered as a treatment option. And this treatment recommendation was based on evaluation of pooled data from the TROPION-Lung01 and TROPION-Lung05 study, in which in the pooled analysis, about 114 patients with EGFR mutant non-small cell lung cancer were treated with Dato-DXd, 57% of whom had received 3 or more prior lines of treatment. And what was observed was an overall response rate of 45% with a median duration of response of 6.5 months. So definitely promising results. Next, we focused on updates to subsequent therapy options for patients with another type of EGFR mutation known as EGFR exon 20 insertion mutations. In this section, the panel added sunvozertinib as a subsequent line option after progression on platinum-based chemotherapy with or without amivantamab. Sunvozertinib is an oral, irreversible, and selective EGFR tyrosine kinase inhibitor with efficacy demonstrated in the phase 2 Wukong 6 study conducted in Chinese patient population. In this study, amongst 104 patients with platinum pretreated EGFR exon 20 mutated non-small cell lung cancer, the observed response rate was 61%. Staying in the EGFR space, the panel added a recommendation for patients with acquired MET amplification following progression on EGFR TKI therapy. In these situations, the panel recommended that treatment may be offered with osimertinib in combination with either tepotinib or savolitinib. As our listeners may know, MET amplification occurs in approximately 10 to 15% of patients with EGFR mutated non-small cell lung cancer when they progress on third-generation EGFR TKIs. And detection of MET amplification is done with various methods, such as tissue-based methods such as FISH, NGS, IHC, as well as ctDNA-based NGS with variable cutoffs. Over the last few years, several studies have informed this recommendation. So I'm going to be discussing some of them. In the phase 2 ORCHID trial, 32 patients with MET amplified non-small cell lung cancer after progression on first-line osimertinib were evaluated, where the combination of osimertinib plus savolitinib achieved an overall response rate of 47% with a duration of response of 14.5 months. More recently, the phase 2 SAVANNAH trial reported outcomes in 80 patients with MET amplified tumors after progression on osimertinib. And in this patient population, the combination of savolitinib and osimertinib achieved an overall response rate of 56% with a median PFS of 7.4 months. And lastly, the phase 2 single-arm INSIGHT-2 trial assessed the efficacy of osimertinib plus tepotinib in patients with advanced EGFR mutant non-small cell lung cancer who had disease progression following first-line osimertinib therapy. And in this study, in a cohort of 98 patients with MET amplified tumors, confirmed by central testing, the overall response rate with the combination was 50% with a duration of response of 8.5 months. So definitely informing this guideline recommendation. Next, we had an update on recommendation in patients with ROS1 rearranged non-small cell lung cancer. For patients with ROS1 rearranged non-small cell lung cancer, the panel recommended specifically for patients who progressed after first-line ROS1 TKIs, the addition of taletrectinib as a new option alongside repotrectinib. And this recommendation was based on analysis of the results of the TRUST-1 and TRUST-2 studies, which showed that amongst 113 tyrosine kinase inhibitor pretreated patients, taletrectinib achieved a confirmed overall response rate of 55.8%, with a median duration of response of 16.6 months, a median PFS of 9.7 months, a very promising agent. Finally, for patients with HER2 exon 20 mutated non-small cell lung cancer, the panel added 2 new oral HER2 tyrosine kinase inhibitors, zongertinib and sivabertinib, as options in addition to T-DXd and after exposure to T-DXd. These recommendations are based on early phase data from 2 trials, the phase 1 Bumion Lung 01 study, which evaluated zongertinib, and the phase 1-2 SOHO 01 study that evaluated sivabertinib. In this study, zongertinib demonstrated an overall response rate of 71% in previously treated patients, with an overall response rate of 48% amongst patients who had received prior HER2-directed ADCs, including T-DXd. Sivabertinib, in its early phase study, showed an overall response rate of 64% in previously treated but HER2 therapy naive patients, and an overall response rate of 38% in patients previously exposed to HER2-directed therapy. The panel believes that both agents had manageable toxicity profile and represent meaningful new options for this patient population.
Certainly, it's an active space of research, and I appreciate you reviewing the evidence underpinning all of these recommendations for our listeners. So it's great to have these new options for patients in the later line settings. And given all of these updates in both the first and the later line settings, what should clinicians know as they implement this latest living guideline update? And how do these changes impact patients with non-small cell lung cancer?
So great question, Brittany. I think for clinicians, when I'm implementing this update, I think about two practical steps. First is reiterating the importance of comprehensive biomarker testing. That is the only way to identify key drivers and resistance mechanisms that we are now targeting. And second, picking a first-line strategy that balances efficacy and toxicity and patient preference for your specific patient. I think informed decision making, shared decision making is more important than any time right now. It has always been important, but definitely very important now. For patients, this guideline brings recommendations on more personalized treatment options for both first line and post progression settings, which potentially means better outcomes. But it is also very important for our patients to continue to have informed conversations about side effects, time commitment, and what matters most to them with their providers. The panel in this version of the guideline specifically acknowledges the real world barriers that prevent patients from receiving guideline concordant therapy, including challenges with access to comprehensive molecular testing and treatment availability. And the panel emphasizes on the importance of shared decision making, and we provide practical discussion points to help clinicians navigate these conversations with the patient. In addition, the panel has also addressed common real-world clinical complexities, such as treating elderly or frail patients, managing multiple chronic conditions, considerations around pregnancy and fertility, and certain disease scenarios such as oligoprogression and oligometastatic disease. And where available, the guideline summarizes this existing data to support informed individual decision-making in these complex situations.
Shared decision-making is really paramount, especially with all of the options and weighing the risks and benefits and considering the individual circumstances of each patient that comes before a clinician. We've talked a lot about all of the new studies that the panel has reviewed, but what other studies or areas of research is the panel examining for future updates to this living guideline as it continues to be updated on an ongoing basis?
Yes, definitely. So much to look forward to, right? Looking ahead, the panel is closely monitoring several rapidly evolving areas that are likely to shape future updates of the guideline. This includes emerging data from ongoing later phase studies, particularly the studies that are evaluating these new targeted agents moving to earlier lines of therapy, alongside studies evaluating additional combination strategies or more refined approaches to treatment sequencing. We're also closely watching advances in biomarker testing, the evolving understanding of resistance mechanism, development of new targets, and promising therapeutic agents. I think ultimately the living guideline exists to help clinicians and patients navigate this rapidly evolving field. And we would like to ensure that scientific advances are rapidly translated into better, more personalized patient care.
Definitely. We'll look forward to those updates from those ongoing trials and future areas of research that you mentioned to provide better options for patients with non-small cell lung cancer and a driver alteration. So I want to thank you so much for your work to rapidly and continuously update this guideline. And thank you for your time today, Dr. Puri.
Thanks so much. Thanks so much for the opportunity.
And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/thoracic-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in the Apple App Store or the Google Play Store. There's also a companion episode with Dr. Royce on the related living guideline on stage 4 non-small cell lung cancer without driver alterations that listeners can find in their feeds as well. And if you've enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.